First, we'd like to thank Brent Edwards, who paid for the coffee and cookies this week. So as you're enjoying your coffee and cookies, we're going to be hearing from Matt Jordan today. So Matt got his bachelor's and master's degrees in kinesiology here at U of C, and then continued on to his PhD, also at U of C in medical science, focusing on joint injury and arthritis. So Matt is now an assistant professor here in the HPL, and his research interests are assessing neuromuscular adaptations to resistance training in athletes, with a focus on knee injury prevention and rehab. He's also worked in a variety of leadership roles in strength and conditioning and sports science, working with elite athletes. So today, Matt will be presenting secondary and tertiary ACL injury prevention. If it's not downhill for skiers, what is it for the rest of the lot? A research update.
All right, thanks. I don't know if Olivia mentioned, but I pinched hit for today's talk, and that means that I was sort of scrambling to pull things together, and it's a little bit fragmented, not as smooth maybe as I would always hope. But hopefully today I'll be able to give you a bit of an overview of what we're up to with our lab. Quick shout out and recognition to my lab group and collaborators, people who've helped out with the project. And here's our lab over in the Oval. It's coming together. We've got ourselves a dual force plate system with our modified squat rack, wireless EMG system, and dynamometer coming relatively soon here towards the end of the month. It will be like a biodex that does sort of closed chain leg press type movements. Really neat system. And this is where we're going to be doing a lot of our work with our athletes here at the university. The research program is pretty simple. I'm interested in everything that relates to muscle strength and power. And if something happens that affects muscle strength and power, it's a topic that I care about. So whether that's aging or injury or training. But in the context of ACL injuries, that's where spent the bulk of our time doing research. And essentially it's three things: trying to develop better tests and strength diagnostics. As you'll see today, that's pretty important. Using those data to help forecast recovery for athletes on an individualized basis, and then ultimately to hopefully improve the outcomes for these athletes after they suffer traumatic knee injury. So 4 stopping points. I'm hoping to spend maybe 10 minutes on each. But I want to talk about a bit about the problem, talk about a biopsychosocial model to approach the issue around preventing injuries, defining a bit of a roadmap around the post-injury recovery period. And then lastly, I'll talk a little bit of data around this question of what type of graft to use after an ACL injury and some of the data that we have. So this isn't easy. I'll tell you that right now. It's a tough thing to prevent injuries. And certainly it's tough to prevent the second injury and then the long-term outcomes, which is things like developing osteoarthritis. If you're an athlete, it might mean not getting back to your pre-injury performance level. But all of these things are central in our world. The burden of injury for something like ACL injuries on a societal level is pretty big. So these are things that obviously, if we're going to be encouraging sport activity participation for all the good things, we try to minimize this. Recently, I worked with Jörg Spori, who's a contact of mine in Switzerland, and we were working on a book chapter around bringing together the whole concept of injury prevention with alpine ski racing, and we really leaned on what we say is the Van Mechelen model, which essentially says we establish the extent of the problem, we look at mechanisms of injury, we introduce preventative measures, and then we see if we actually change that baseline injury rate as sort of a cornerstone of how to understand injury prevention. And I've spent the most of my work in ski racing, but as you're going to see, we're transitioning now over here to the university for our research. What we found over lots of research with alpine ski racers is that these are frequent injuries, ACL ruptures, traumatic knee injuries in general. They're severe injuries, and they're injuries that have all sorts of consequences around the development of joint degeneration, getting back to skiing, and to your pre-injury performance level, and of course, re-injuries. Again, sometimes this sort of seems normalized, like it's an ACL rupture, like getting your wisdom teeth pulled. Everybody gets it, right, at some point. But really what I can tell you based on the work we've done is that it's anything but. These are very severe injuries that do cost these athletes a lot of time and obviously really compromise their health. So looking at the incidence of ACL injuries, it is the most frequent diagnosis, knee injuries being the most common part of the body that's injured. It's really interesting with alpine ski racing, there's actually no difference between males and females at the elite level in terms of ACL injury rates. There is a bit more of a difference when it comes to adolescent age skiers, but at the top level, it seems like something's been washed out with what we typically associate with as a higher proportion of female athletes who are suffering ACL rupture. Lots of great work has been done looking at some of the factors that contribute to ACL injury in ski racing. There are things like, number one, these sort of twisting forces that act on the knee joint because of that ski, and obviously the forces imparted by the boot. And what we think also are some sort of level of imbalances between how the quadriceps and hamstrings are regulated in terms of the neuromuscular control strategy. These are also coming alongside with things like technical errors, tactical errors. Core strength imbalance has been identified in skiers as a potential injury risk factor. But taken together, these injuries happen in sort of these very complex multiplanar ways and in a very short time frame, as you can imagine. So we're now really fortunate that we're here at the university, and we've had some excellent support by the university for examining return to sport after injury in Dinos athletes, so the varsity athletics program. And so we've started to transition a little bit more to a broader look at some of the other sports that are carry with them a high risk for ACL injury. So this was a paper that we just finished working on with some of my collaborators from the US, where we were looking at mechanisms of injuries in NBA basketball players. And just to show you the dramatic difference between, let's say, a skier and a NBA basketball player, again, it's multiplanar, the injury happens quite quickly, but we see these distinct injury mechanisms that typically involve this outstretched position of the foot, sometimes associated with trunk inclinations and rotations, all of which are believed to put this sort of rotational load on the knee joint. It's kind of interesting to note that one of the common beliefs is that the kissing knee thing is the injury mechanism, that knee valgus. It's very interesting to note that we didn't really see that in these basketball players. In fact, it was more of these extended knee joint positions with rotational forces that seem to be related to the moment of ACL rupture. And the other thing that's going to be important as we move through today's presentation a little bit is the idea of situational factors. So it's not happening in sort of these situations where everything's perfect and sterile like in a lab. The athletes are reacting to their environment and typically doing some sort of evasive maneuver to try to create deception against their opponents, which are sort of cornerstone to what seems to happen in these circumstances. Really have enjoyed so far working with Dr. Kati Passanen, who's sort of co-leading our integrative neuromuscular sport performance lab, and she's done a lot of work in this area in court sports as well. And it's interesting to note that one of their studies where they looked at change of direction biomechanics in athletes who went sort of high risk for ACL rupture in handball and in basketball, again, they found some interesting findings. Number one, that obviously it's a fast multiplanar type occurrence. 6 times more ACL injuries in the female athletes compared to the males, so different than skiing. This whole idea of the knee valgus kissing knee thing was actually not associated with ACL injury risk in their baseline change of direction screening, so contrary to what the popular belief is. And again, what they found was this combination of situational factors and sagittal plane loading. So, you know, it's almost the analogy I sometimes use is, are you a really rigid, stiff system? Are you like an Audi S4 with tight suspension, or are you a squishy Cadillac? You know, and you can think about it sort of being optimal, but what you're going to see as we work through the presentation is that being stiff may not be so great. And it also seems like, especially around ACL re-injury, being like that squishy Cadillac is potentially a predictor of a future ACL re-injury. So, you know, obviously these sports are prevalent, ACL injuries are prevalent, and we've got, you know, a lot to manage, but it's kind of interesting to look at the data in terms of what athletes' expectations are about their return. And this is a very interesting study that looked at simply athlete expectations. And here what you see in blue is the expectations that the athlete's going to return to that pre-injury performance activity. or that pre-injury performance level and their competitive activity of choice. Comparing at the time of your first ACL injury, and then how that changes with your second. So we'll see that athletes actually expect after their ACL rupture and their reconstruction that they've got a good chance of getting back. Things seem to change with time after the second one. And when we actually examine this a bit more systematically and we look across sports in general, what we find is that the reality is a heck of a lot different than the expectations. So while 76, 80% of athletes think that they're going to be back to what they were doing, when you actually look at the data, about just a little over half are back to competitive sport after an ACL reconstruction. And so, this is sort of the expectations versus the reality is quite stark. What else do we know? Well, proportion of athletes getting back is surprisingly low, a little over half. It seems to be a little better if you're an elite competitive athlete with all the resource. There are sex-based, gendered, environmental, psychological, and physical factors that exist that seem to determine the success here, highlighting the fact that it's not just one thing, it's probably multiple things that sort of promote that sort of potential to get back to the things that you've done before. It seems like athletes do get back to performance, but when you actually look at performance capacity with measurables, so this might be points scored or speed or things that are related to actual performance in the sport, there seems to be a measurable loss in performance. Despite the fact that you're back, it's like you're missing a step, if that makes sense. The risk of osteoarthritis increases, especially in conjunction with severe combined injuries. So sort of along this lines of, 5 to 10% have OA around 5 years. That works all the way up to about 50% at 20 years after an ACL injury. But this is where it gets a little bit more alarming. 20 to 40% are going to suffer re-injury with a 2-time greater risk for contralateral ACL rupture after that first ACL injury. So we know the best predictor of that next injury is having had one before. And this is the last part that is surprising as well. You would think that after decades of research on this, that we would be somewhere where we have a clear sense of what we should be looking at to guide return to play. But as you're going to see, is that our evidence is lacking extremely in this department, and it is not well defined at all. So more about that in a bit. I try to put this into context, and this is why I call sort of why I get pulled into this research. But I've shown this video before, but it's as some of my team members, my IST team members, medical staff would say, it's the regrettable case, right? So this is the reality beyond just the data and the statistics. This is an example of what we were contending with ski racing, which was that 20 to 40% of our athletes were going on to suffer another injury, typically to the contralateral knee. You actually see the athlete clutching that knee, right, as he tumbles down the pitch. So he was a left side ACL injury. He was a part of our cohort of skiers that we initially started studying. So in this case, he's about 14 months post-surgery. So again, at 14 months post-surgery, that's like a year and a couple months. Everyone would say, "Oh, you're clear," right? Based on time, that seems good. But was very interesting about this athlete is that when we examined our cohort of athletes, this was our initial study looking at some new measures of neuromuscular function in these athletes, where we were using that dual force plate system and jumping to look at the contribution of the total ground reaction force from the left and the right limb. This was our athlete. He was the single athlete in the cohort with these asymmetries that we observed to be above 20% side-to-side differences in our various measures of neuromuscular function. And it's just really interesting to know, again, this is anecdotal, and I've been able to get permission from this athlete to share it. But I remember being there at about, it was about a year and a bit after surgery, and he's doing his baseline testing. And I can remember being like, I really don't know if I'm ready. Remember that actually discussion downstairs at the Biodex. And, it just sort of brought to light at the time that we weren't really using criteria. We were using more of time and just sort of saying, well, but what am I going to do? It's 14 months. I gotta do it sometime, right? Was sort of the position we were in. But nevertheless, this idea starts to bring up this idea of, what are we missing? What sort of science can we bring behind the practice, and how can we take a more integrated approach to potentially manage this high risk environment of an athlete coming back after what I would say is a very, very serious injury. So that's the segue into a biopsychosocial model. And I think that's kind of the key point here. I could probably summarize this slide just by saying it's not a single thing, right? If you're talking about managing injuries and you're talking about managing the return to sport process after an injury, it's certainly not just your strength or just how you move. It's also how you feel, right? It's your confidence, it's your fear of re-injury, it's how you play the game. Many of these things are coming into the equation, which obviously leads you towards this idea that if it's a complex system with multifaceted, bunch of factors that are all in the soup, we have to understand what these are in advance as we start to frame up a model of research to study this problem. Winneme-Wissa, who is for newcomers to the HPL, you may not have heard of his name before, but Winneme-Wissa was a sport medicine physician here for a long time who has done a bit of a pioneer in the space of injury prevention. And Dr. May-Wissa had a model, sometimes referred to as the May-Wissa model. He had a couple of iterations on it, but this particular model talked about how do we understand the whole process around injuries. And I could summarize this slide by saying, you can imagine driving to Canmore on the highway and you're not wearing your seatbelt. You might sort of do it as humans say, as I actually think I drive more safely when I don't wear my seatbelt. And certainly not wearing a seatbelt, doesn't cause an injury per se. In fact, I could wear my seatbelt and have to slam my brakes on and I could get hurt. But it's that whole idea of, in this context, about the things that are sort of multifactorial when it comes to injury, and the idea that there are some things that we do that are protective against injury. Certainly, we can't understand injuries just by a simple approach. There are many pieces about it. We need to have some sort of exposure, like driving our car. We need to have some sort of inciting event, like I need to slam my brakes on. It might be a little bit icy. But you can imagine in a scenario that there are things that I am doing potentially internally, wearing my seatbelt, that might be protective against that injury. And in this context, we sort of understand injury as this idea of having multiple components like, internal risk factors, things that are modifiable and non-modifiable, understanding this in terms of exposure and exposure to this environment. And obviously this process being a bit of a loop, right? So once you've been hurt, you're now in this loop where your best predictor of a future injury is the fact that you've been injured before. This model is frequently updated, and it was recently updated by Tim Gabbett and Johan Wendt to say, hey, don't forget that there's also this effect of training, right? So when we train and we exercise, it actually is a protective thing. Now, on the other hand, maybe training a lot and potentially training too much could lead to fatigue factors, where that diminishes your ability to protect yourself against an injury event. But in this model, we sort of see that there are things that we can do that are ongoing in terms of how we train, how we exercise, how we recover, that in this environment might help us understand injuries a little bit more effectively. So Zach, who is funded by the Dinos Excellence Fund to do some work in this area, has been spending a lot of time and researching around what do we know about injuries in collegiate sport and around traumatic knee injury as well. You would obviously sort of build towards the presentation, start to see that late adolescence, early adult period where you're sort of a teenager in your early 20s. It's a very precarious time for injuries, and obviously lots of biological development, social development happening. And so we started with a review of the literature to see what's out there, what do we know? And not surprisingly, there was one paper that was examining this sort of relationship between training, fatigue factors, and injury in a very observational sort of design, not in a robust sort of systematic way. But nevertheless, we found one. We expanded that literature search and we looked down in towards the United States and included the NCAA as part of our review, and we found maybe another 12 or 14 papers more in that body of work examining these various factors. So it's kind of leading us to now this crux of the problem is that we don't understand injuries that well. We don't understand the recovery process that well. It's not well defined, but we want to study this. And so part of the process now is to begin to work on a bit of a model that we can apply here in the context of a sort of a well set up longitudinal environment. Athletes enter at, let's say 18 or 19 years old. They're here for 5 years. They come in with some history. And I guess building out a model that we can use to study the problem of basically injury prevention, both from the primary, secondary, and tertiary standpoint. So as we've sort of been working through this over the past 8 months or so, we've arrived at a bit of a model to explain and to potentially say, hey, here's a way maybe that we can study the whole context of injury prevention in a collegiate setting. Obviously, athletes are coming in with some sort of training history and some sort of injury history, which we believe to be important to capture. I thought this was interesting to put up just as a contextual factor that I think is often overlooked. This tweet came out probably a couple of years ago, but it was from a college basketball player in the US who was tweeting an image of their weight room, the women's weight room compared to the men. And this idea that, hey, folks, what do we have in terms of resource to support the training environment that we're using for, preparing athletes sufficiently to prevent injuries, et cetera, et cetera. So this is something that, we've introduced into the model. And we've said that, in essentially building off a good friend of mine and colleague, this idea of understanding the female athlete and understanding, the whole space around injuries. It's a great quote to say, in reflection of the numerous studies investigating the differences in athletic performance and risk of injury in male and female athletes, I question whether a lack of control or consideration of physical capacity, things we can train, things that we support through resourcing or skill, potentially confounds much of this research. So this idea that, we need to take a bit more of a broad approach to how we study this problem and not just look at the physiology and the biomechanics, but also some of the factors that influence the bigger picture. So in this model, we've sort of started to discuss the idea of load tolerance, which I believe is relevant to the room in the sense that, at least conceptually, we imagine tissues at any point in time to be some sort of continuum in terms of their tolerance for load, whether that's bone, ligaments, or otherwise. We have obviously an important paradigm that we're operating in with the coaches who may have their own views on how to prepare athletes. They are the key individuals who are prescribing training or designing practices, right? So that is sort of the application of that external load. There's an internal physiological load that's incurred by the athlete themselves, where there's a response, which includes components of fatigability, which is maybe not only the diminishment of my strength and power due to fatigue factors, but potentially also how I feel. You can imagine university athletes who are undergoing 5 exams in a week, right? Versus the others, maybe teammates who have 1 exam in a week. These sorts of things maybe confound or potentially change the dynamics of a university college or a college athlete. In our model, we sort of see this loop as either augmenting or diminishing the athlete's readiness and their overall training level. And then incorporating Dr. Maywissa's model, we sort of see another side of the equation here, which is for the injured athlete. And this is where Zach and I are going to spend most of our time studying this around the Dinos athletics. But in the context of injury, what's a model that we can use to potentially understand and study this with what's basically a very nice longitudinal design to be able to follow these factors over time. Just a quick mention as we transition to the next part of the presentation, but another aspect of our research program at this current time is that a lot of the data is observational. So it's very difficult in this environment to run randomized controlled trials or to really understand cause and effect relationships. So part of what we're doing with our research and our sort of maximizing the potential of observational design here is to use some different statistical methods, including methods like causal inference or machine learning to help tease out the relationships between these various factors in our map. Okay, but what about the roadmap? Not surprisingly, when you start talking about ACL rupture and you start talking now about that right-hand side of the previous slide, which is all the factors involved with managing the injury, recovery from injury, trying to prevent re-injury, getting athletes back to performance. You would think that we have, this sort of defined out, but when you look at the evidence, what seems to be the case is that practitioners tend to rely on time as their main factor driving return to sport readiness. So, I noticed this a lot when I was initially starting out my career as a strength and conditioning coach. It was largely driven by, the surgeon or the physician who would sort of check the joint and ask some questions, and then maybe a subjective evaluation, maybe not. But once enough time had elapsed, that was sort of the main thing determining when the athlete would be ready to get back to sport. And that's actually what the bulk of the evidence suggests is the accepted practice. When we do run protocols to look at return to sport readiness after traumatic knee injury, the standard right now is typically a series of hop tests, which are done in the clinic environment. So this might be things like a single leg hop for distance, or a triple hop, or a timed hop, performance-based tests. And a recent meta-analysis looked at the validity of these tests. And it was interesting that they found a small reduction in the risk of a re-rupture of the same leg when you pass criteria. But it was very interesting that passing criteria was associated with a 235% increased risk of contralateral knee injury. So the criteria you use to determine the readiness to get back to sport is actually something that is a stronger association with that risk of rupturing the ACL in the opposite limb, which is a bit alarming when you think about this. Another thing that we're contending with this roadmap is we know that an injury doesn't just affect your injured side, it actually has an effect on the contralateral limb as well. And so we know that in this context that our typical benchmark is we don't have a pre-injury profile, we don't have normative data, so we use your other leg as our benchmark. And we establish a threshold, 85%, 90%, 95%. Recently, some practitioners and some researchers have been calling for maybe it should be 105%. But the typical one you hear is 90. And this was a very interesting study, and they didn't have pre-injury data, so they used what they called an estimated pre-injury capacity as their sort of benchmark, and they compared it with, so basically estimating what they think you should be versus measuring against that contralateral limb as a measure of criteria for return to sport readiness. And this table here is essentially showing the number of athletes that passed criteria. And the whole notion here of this standard practice of these hops for distance and the contralateral limb, the main take-home message is that the tendency is thinking right now is that it's leading towards these false positives for readiness to get back to sport. We've also seen that as well. This is an example from one of the case studies that we used for our scenario of monitoring an alpine ski racer after an ACL injury. We were looking at a whole variety of neuromuscular measures, and two of the measures that I'm showing here are obtained from isometric dynamometry. So here performing knee extension and knee flexion. We perform these contractions to look at not only the maximum torque that's generated, so a measure of their maximal strength, but we also look at what we call the rate of torque development, which is a measure of what we call explosive strength. And in this context, the idea is that, well, number one, from a training standpoint, we would train a maximal strength deficit differently than an explosive strength deficit. So that's one thing. But the second thing is that in the literature, there's this emerging thinking that there potentially is a delay in how athletes are able to restore that fast force production relative to the maximum force production. And so these are some of the things in the literature right now that are emerging as potential areas to look at to help mitigate some of the concerns around ACL re-injury and that performance loss. So where I wanted to show sort of that idea of the importance of a benchmark how do we define a benchmark? Is it the contralateral limb? Is it some other standard? We used this study where we were examining the post-injury period, and we had measurements at 18 months post-surgery for the athlete. On the left panel, panel A here is the maximum strength capacity. And then on the left, and on your right panel, this side B, is their explosive strength capacity, so how fast they make torque. First of all, starting with the ACLR limb, you'll notice that by 18 months, pretty robust improvement in that ACL limb's strength. But you'll notice that the explosive strength capacity is still not showing the same relationship. So this is a little bit different than what we see when we aggregate our data, because it seems like most of the time, the explosive strength is explained by the fact that the limb is just not strong. So we're trying to understand this a little bit more thoroughly. But in this case, you'll notice that strength is improved, but the capacity to make force fast has really stayed flat over the course of recovery. This was a hamstring tendon autograft. So you'll notice a modest improvement in strength of the knee flexors. So they removed the hamstring tendon for reconstructing the torn ACL. But this was the main thing that was a bit shocking for this case study. It was one reason why we decided to examine it. Was if we look at the contralateral limb strength and explosive strength over the 18-month time period, almost like a linear loss in strength capacity throughout that time period. So again, purely being presented from the idea of, is that contralateral limb a good benchmark? Because I'll show you right now that the asymmetry index looks pretty good. But it's not good because we have two strong limbs necessarily. We've got one limb that's detraining and one limb that's increasing in strength. Another aspect that I think is emerging and also really interesting, and it has to do with this idea of, are you an Audi S4 or a squishy Cadillac? I think this is one of the better studies to have examined predictors of re-injury for an athletic population. They measured athletes at 9 months post-surgery, and then they followed them out over 2 years. So these were athletes who'd suffered an ACL injury. And in this particular study, it was really interesting because they used your conventional measures of return to sport readiness, like your hops for distance and limb symmetry indexes and whatnot. But they were also able to conduct some quite robust biomechanical testing. So they used 3D motion capture and kinetics to look at change of direction mechanics. They also used those measures to look at vertical jump stiffness in a drop jump task where an athlete drops off a box and basically reacts off the ground to jump as high as they can. And what's so interesting about this study is none of the conventional measures had any association with ACL re-injury. In fact, about the only things they found was that in the sagittal plane, so now we're not talking about the kissing knee thing at all, we're saying in this plane, were things like the stiffness strategy that was used in the jumping was found to be a predictor of a future risk of re-injury. In this case, this silhouette is showing the group that got re-injured, and this silhouette in the background is showing the group that went on to fare well. So the leading sort of thought here is that there's something around how these athletes are regulating their stretch shortened cycle capacity, which is their ability to couple eccentric and concentric movements that might be sort of part of this puzzle about a future risk for a re-injury. We did something similar in a group of elite skiers, females, where we had 41 athletes. We had 30 who were non-injured. 6 athletes had pre-injury data, 17 had post-injury data. And we were able to look at them over a pretty long time period, so 16 years. Where we were using the counter movement jump, which you see on the screen as a primary diagnostic of their stretch shortened cycle capacity. And our ACL injured athletes were able to sort of be followed up over a 5-year period. So in total, there were about 567 jump tests that were a part of our data set. And we looked at a whole range of variables to come out of this vertical jump. So it's not just how high did I jump, but it's actually how did they jump? Were they a squishy Cadillac? Were they an Audi S4? Did they spend a lot of time on the ground, a little time on the ground? Were they stiff? Were they not so stiff? How did they put the brakes on in the bottom? So how did they decelerate their body center of mass? I know it's not a really good mechanical term, but bring their center of mass to zero as they start to descend into the bottom position. And what we did in this particular study is we looked at it 2 ways. We looked at it in terms of the contralateral limb and an asymmetry index. And then we also used a benchmark where we actually took our non-injured control group and we established what we thought to be a sort of a threshold. What we would say is, what should they look like based on female skiers who are at the World Cup level who are non-injured. And it was quite interesting. This black dashed line denotes that sort of target value that we set. But it was very interesting to note that while the interlimb asymmetries just showed that they were back to normal at about 1.5 years after surgery, when we looked at the data over the long term, which was over a 5-year time frame, it was really clear that those athletes had not reached that sport-specific benchmark of neuromuscular function. So it kind of leads to that idea of, like, how do we define this? And right now, I sort of feel that it's wide open. There's not a lot of really compelling data, although it's emerging. One idea that we're having and sort of thinking about in the context of sport specificity is to leverage the environment of a monitoring environment, where we have factors, obviously, after injury, like time, which are natural part of the recovery process. It's really important to say that this time-based criteria around tissue healing seems really, really important. One example is around the hamstring tendon and the autograft. There's new emerging data that's showing that even 12 to 24 months after that reconstruction with a hamstring tendon, it's still remodeling and actually undergoing sort of a process of ligamentization is what they call it. But this idea of becoming more like a ligament. So we know that time is crucial, but we also know that in an environment like this, where we have a bit of a closed loop, is we can start to expand upon more frequent testing. So a limitation of the study I just mentioned about the 1,400 athletes where they used the biomechanical testing, they tested at 9 months and then they followed up for 2 years. And I guess I would question to say, how does a picture at 9 months tell us anything about how they looked at 2 years, which is oftentimes where the athletes actually suffer the re-injury. So we know that inherently movements we're variable when we move. It's not a stable, static thing. But what we sort of are proposing is this environment of, kind of a closed sport environment, is we actually have the ability to undertake what we call daily athlete monitoring. So this idea that we can do routine testing every few weeks with a battery of tests. We'll be able to collect data around wellness and some of these gendered environmental factors and social factors. And we'll be able to use that sort of as a underpinning to be able to understand what this return to sport, return to competition, and return to performance transition looks like as we sort of manage this. And the last little point I'll mention here on this slide, and this is part of the Dinos Excellence funding, but really making sure too that we have the components of, the mental performance aspects, right? The clinical aspects and the physical aspects intertwined in the body of study. In terms of our lab, I was inspired by a paper from Scott Dye. This is an older paper from 1996 that he was defining this idea of tissue tolerance to load. And I put this on mostly inspired by Brent because of the work that he's been talking about around bone and how we understand bone loading. But I thought it's a really interesting model because what Scott Dye talks about is this idea that if you imagine functional capacities, and if you think about it in the context of injury, where at one end you've got these high load events, which are happening more infrequently. And then at the other end, you've got these fast repeat movements that are happening, which are lower load, but potentially faster and more dynamic with obviously higher frequency. The idea is if we could define this before an injury, and we could define this in a sport-specific, sex-specific way, we would actually have a pre-injury profile against which we could compare our post-injury recovery and start to understand this in a little bit more of a specific way. So in our current endeavors, this is the dynamometer that we'll be getting sort of at the end of March, hopefully, which is a sort of like a closed chain biodex capable of moving more than 6 meters per second, but also able to move under high force conditions. So we can look at eccentric and concentric muscle function in a very specific way. One of our cornerstone tests are these loaded jump tests where we apply an external load to the athlete during jumping. We've got our standard counter movement jump test, and then Nathan Boone Van Mossel is working on a a fast repeat stretch, shorten cycle movement, which we call a cyclic hop or a reactive hop. But through this way, we're aiming to define this envelope of function and hopefully to establish this as a potential pre-injury criteria against which we can compare recovery after injuries are sustained. So in the final 10 minutes, I just thought I would spend a little bit of time on this graft question because it's another question that comes up quite a bit in our world. There are three main graft types that are used currently for reconstructing a torn ACL. There is to take out the middle third of your patellar tendon and a chunk of your bone. And then that is used as a graft, so put in through some tunnels. There's taking out your semitendinosus tendon, which is that big rope tendon on the back of your thigh. That whole tendon's removed and then folded up and used as a graft. And then there's this emerging data around the quad tendon, which is actually using still obviously from the extensors, but using a different part of that extensor muscle tendon unit. And it's a question, you know, like what do you use? And I thought this would be an interesting place to end the conversation. So the first thing is clear. Sometimes I do this when I'm teaching it, but if you feel in the back of your knee, that big rope of a tendon on the inside is removed. And I used to think, oh, it was a part of the tendon maybe, or a third of it. I didn't really know. I couldn't conceptualize this when I was a young strength coach working with athletes who had these grafts. And I remember being in the OR with Mark Hurd, where I was watching him do surgeries, which was a lot of fun. And I remember the first time I saw him do an incision on pesa and serine, hook onto semitendinosus with a little, looked like literally a hook, and then took what I think he called a tendon stripper, but just literally pulled out the semitendinosus tendon. I said, Mark, you took the whole tendon. He said, yep, sure did. Oh, there's a couple connections here. I'm like, I don't know why. I never thought that. I thought you would leave part of it. He's like, no, took the whole thing. I'm like, of course, like that. I never wrapped my head around that. So you can imagine you've torn your ACL, but after that point, it is a neurophysiological injury that is not just your ACL. It's the graft. It's how you learn to use that knee again, sensory motor control. It's a complex thing. But the comorbidities that come from taking your own tissue are another piece of the puzzle for how we rehabilitate an athlete after an ACL injury. So Dr. Matadi has done quite a bit of work in this area to examine the occurrences of re-ruptures and contralateral knee injuries with various graft types. In this particular study, it was comparing a couple different graft types, and I've just highlighted the main thing here. The main take-home message is that there's a small but statistical effect of graft type on re-ruptures that's in favor of using a bone patellar tendon bone graft. Meaning, if you take the bone patellar tendon bone graft, you have a slightly better chance of not re-rupturing that ACL, which is kind of interesting. Another little piece of the puzzle, which why I sort of highlight on the, sorry to segue back, but on the late adolescent, early adult athlete is actually, there's a statistical difference for younger athletes in terms of the occurrence of re-injury. So we know that younger athletes, female athletes, and certain graft types are all things that influence the occurrences of re-injury. Especially in the context here, I think that's a vital piece of the puzzle if we're going to understand how to improve outcomes for younger athletes who are in their late teens and early 20s. But main take home is this. So we see this on the other hand, though. So you get a little bit in favor of not re-rupturing, but we actually also know that athletes who get the bone patellar tendon bone graft tend to recover slower. So if you use your benchmarks of recovery, which are things like triple hops for distance, these are the standard hops which don't appear to have a lot of validity for looking at risk of re-injury. What we see is that bone patellar tendon bone grafts are the ones who display slower recovery. So if you're going to be getting a graft that maybe is favoring you a little bit around not re-rupturing, we have to mitigate the other side, which is time course for getting back to sport. So it's not all created equal. The other thing what's really interesting about this study, and a little bit of a side note, of course, is you can imagine removing your semitendinosus tendon, right? Removing this tendon, we see a dramatic effect on hamstring strength, particularly in the inner range of the hamstring muscle. So because of the moment arm of semitendinosus, it's pretty long in a more bent knee position, we find that athletes who get that graft type are actually quite a bit weaker in that inner range. So many of these protocols here don't tease that out in the return to sport testing, which is why we say return to sport testing should be multifaceted, not just one thing, but we're looking at all the components of the lower body in terms of muscular strength. Why this is a particularly important thing here is that in our cohort of skiers, it tends to be the graft of choice, mainly because of the fact that when you ski, there's a large eccentric load on the extensors, and athletes, from what I understand, typically haven't fared well when they've gotten a bone patellar tendon bone graft, so they opt for this. But back to this whole idea of comorbidities and graft type, you might be favored in terms of, the idea of some studies are showing that hamstring graft is a better chance of getting back to sport and obviously getting back more quickly. But we do know that there are some substantial impairments in strength that happen alongside that. And Nate Morris, who was with Walter and myself, did a really nice study where he was looking at how the hamstring autograft impaired knee flexor function across the range of motion. And just as an interesting aside, we found in this ACL group, when we were looking especially at their explosive strength capacity, which is that, again, that ability to make force fast, is that in those inner ranges of knee flexion, so when the knee was more flexed from, let's say, 70 degrees, 90 degrees, and into 105 degrees, that there were substantial strength losses at that 12 months post ACL reconstruction time point. So these are sort of long-term effects of the ACL injury and the surgical procedures that are used to help fix that knee. So I'm just going to wrap up by talking a little bit about some of our jump asymmetries and some of the differences we see with the graft type. Our protocol is to use what we call a phase-specific approach. And one study that I've just finished off with two colleagues from South Africa was to use statistical parametric mapping to look at the force time curves in athletes with ACL injury, pre-injury, post-injury, and as they recover. And what we were comparing was how do they recover in terms of their functional asymmetries. And what you'll notice here is that at time point 1, which is about 3 to 4 months, or about 4 months post-surgery, you'll notice that there is an asymmetry that extends from this first peak across to the second peak. This first peak is what's associated with that braking phase of the counter movement jump, where you're actually reversing your downward acceleration. And this is the propulsive phase, where you're coming up and off the plate. And one of the key things to note is that we found that the recovery was actually time dependent, depending upon the phase. So as I show these final few slides, I just want to say that we're going to be talking about sort of a phase-specific recovery in asymmetries, where we're looking at this braking phase and propulsive phase separately, which we define using this simple approach by obtaining the velocity of the body center of mass and using that to define the various parts of the force time curve. So key thing here was to note that, again, back to graft types, that bone patellar tendon bone grafts seem to take longer to meet their discharge criteria, which is what we discussed from the previous slide, but also that they tend to demonstrate increased asymmetries in jumping. So this fact that a bone patellar tendon bone graft is leading to these more pronounced functional deficits relative to the hamstring tendon. This has been shown by some other researchers. This is the same group who studied the 1,400 athletes in that prospective design and looking at predictors for re-injury. But this is our final little point here on a study that we just published last year. But again, looking back over 10 years of testing, we had, in this case, almost 3,000 tests from our non-injured control, 582 tests from our ACL group. In this case, we were looking at counter movement jump asymmetries in those two phases, knee extensor strength and explosive strength. And we have an emerging group of bone patellar tendon bone grafts. It just hasn't been a big part of our research sample up until now. It's growing now because it's a more common graft type in the sports that we're now working with. And the main thing to note, again, about this idea of graft type is we also observed the fact that the recovery process for athletes with a bone patellar tendon bone graft was delayed. So here what we're seeing is that bone patellar tendon bone grafts, which is represented here by the teal line, you'll notice that they start with higher asymmetries, but they also have a different pattern of recovery over time. We also notice as well that while strength was sort of back by about 400 days post-surgery, you'll notice that our measures of fast force, explosive strength, and I realize that confidence interval is massive due to the fact that we just don't have a lot of data there. But as we start to understand this problem, we may start to sort of see that we look at these different capacities look at them differently to be able to most optimally design our rehabilitation programs. So to wrap it up, main goal today was to just give a research update and to share a bit about what we're trying to do and how what we're trying to do here at the university with dynos and how that differs from the skiing population. There are some similarities in concept, but lots of differences in terms of the problem itself. I wanted to present this idea of a biopsychosocial model and a way to better study athletes in a longitudinal design using observational data and to understand this problem from a biopsychosocial response. The issue with road mapping this and actually defining what is recovered, what defines ready to get back to sport, this is really not well understood. And then to finish off by just presenting that central question around that we have around what graft do we get and how do we manage recovery and some of the emerging data on that. So with that, I'd like to wrap it up and thank you very much for your attention.
Let's get started with questions.
Thanks, Matt. Well, thanks for pinch hitting for us.
No problem. My pleasure.
That was really nice. First question is, what's responsible for the reduction rate of foot development?
Well, I mean, the thoughts are, number one, a neuromuscular control strategy. So there are things such as the rate coding of motor units and some other properties, they call them doublets, but these fast bursts of motor unit activity that occur at the onset of contraction that are believed to be a part of sort of implicated in this. There's a piece around the fiber type in terms of fast versus slow fibers. The series elastic stiffness is thought to be a contributor as well. And those are a few of the physiological mechanisms that are thought to underpin fast force, whereas a lot of force is cross-sectional area, rate coding as well, but motor unit recruitment being a key driver of making a lot of force.
That's a lot of questions. So
yeah,
ideas.
Well, I think so, and I think it's the challenge with the injuries, like an ACL being a mechanical restraint, sure, but it's relatively flimsy if you think about it in the context of the forces that go through the body. But what we do know is it's a sensory organ. It's rich with mechanoreceptors and provides a ton of information back to the central nervous system. And we know that these the neurophysiological consequences of an ACL rupture are extending beyond just sort of a single strength capacity. It's a whole range of things that it seems to impair.
Thanks, Matt. Thanks again for okay, convince me that this is a bad idea. For high elite level skiers, let's just give them all prophylactic ACL surgery before it even happens.
Before it even happens.
Yeah. Just give them all, do something, beef up their ACLs going.
Well, I mean, so let's take the reverse side of it, is that there's a few studies that have been coming out and keeping my eye on them about this idea that the repetitive strain and stress on the ACL potentially, leads to problems, right? There's also some evidence that in athletes who have a preferential landing leg. It's my figure skating landing demo. But they'll have a hypertrophied ACL. There's a lot high protein turnover in the ACL as well. So I think the idea that you could potentially boost an ACL's strength with some measure is
like you mean like you could maybe exercise?
Yeah. I think that would be I'm just sort of saying as a starting point, I think would be an interesting concept. Now the idea of I mean, I don't know how you would go about this process in terms of like, are you saying like potentially go in there and cut it and stick something else in there that makes it better?
Maybe just give them an extra bundle. Like leave the regular ACL in there and then do the hamstring graft or whatever, or some other place, or take a big ligament or something and just stick it in there. I'm actually not half joking because when I think I've already said this in this room multiple times. I should even verify that it's true. But I think during the Vancouver Olympics, it was something like 100% of the U.S. alpine ski team had ACL reconstruction, and 90% of the Canadian ski team had So to me, the statistics suggest that if you ski at an elite level, you are going to have an ACL.
Yeah.
Probably, more than likely. So it's almost like, is it ethical to put people out there to ski?
Well, I mean,
that they're
no, I mean it's a central question as well too around this idea of like, when do you tell somebody to get back to a high risk activity and this promise that you're going to be good? I think that's part of the issue that I was trying to elucidate here with this idea of the expectations around an ACL reconstruction and that you think you're going to be able to make it back. But to kind of rewind to really be specific about the question is, obviously I wouldn't be in favor of doing that, but I would be in favor of ways to look at how do we understand the turnover of the ACL with time, because what you're describing is sort of this idea, like if you're using that joint improperly lots and lots, and it's leading to sort of a maladaptation, which is your surrogate of like your ACL shrinking and is flimsy, versus we're applying the right type of mechanical load and it's getting stronger and hypertrophying. That to me might be a really interesting way to study that change in the tissue with loading, which I think is kind of maybe a nicer way to do what you're saying.
Yeah, and maybe along those same lines, like how many skiers that have not yet had ACL surgery choose to wear a brace? Like, is there any people that do wear a brace that have not had like reconstruction?
Yeah, it's not common, to the best of my knowledge. And I know it's been a while. There's a conference that we go to over in Europe, International Conference on Science and Skiing, where that's comes up a lot. And I know that it's being asked. Some of the concerns, does it disrupt performance? Is there, I don't know, some of those issues, but I think it's an interesting question. I know offensive linemen are starting to wear braces.
Yeah, that's what I was thinking.
Right? That's almost coming standard. You watch college games, they've all got braces on now.
Yeah.
So I can see that being the day.
You may have pictures of an ACL injury that are less complicated than this one. I mean, about 5 times, whatever. Do you have some pictures like that?
Yeah, well.
And the question is, if you use those pictures where the whole mechanism seems to be simpler, to do a free body diagram?
Yeah, well, we didn't do for the NBA study, we didn't do any free body diagrams, but I think that would be pretty interesting to do.
If I look at literature in ACL injuries, I see very little that, especially in skiing, very little that does something to understand the mechanical situation.
Yeah.
But the reason that I'm asking is that about 25 years ago, I was in a court case of a football player, and that football player had ACL injuries on both sides, in different games. I was asked to say something about the mechanics, and I tried to do a free body diagram that would show that the forces were too high. But these were all injuries that happened without any contact with the opponent.
Yeah.
Just running and suddenly make click.
Yeah.
And when I tried to do a free body diagram, I could not make one that would explain the injury. Except if I assume that some muscle groups would not fire for a certain time.
Yeah.
So I have the feeling that certain injury mechanisms are not at all discussed in that skiing research area. And I think maybe the answer to your question may be in that.
Yeah, I agree. Yeah, I agree. I think there's a piece about that neuromuscular control strategy that I think is really, really interesting. And there's back to that conference, the International Conference on Science and Skiing. There's actually a paper from, I think the first author's name is Barone, but they were studying ACL injuries or they were studying something unrelated in skiers. And one of the skiers, they were high-level skiers, and they were recording EMG from the muscles and kinematics and whatnot. And one of the study participants happened to tear an ACL in the study. And it was quite interesting in this, because now they have all this data that they didn't expect to have around this case study ACL injury. And to the best of my memory, the thigh muscle coactivity and how the muscles were being used seemed to be implicated in that injury event. So I think it's a big piece of the puzzle. Yeah.
As long as we're on the mechanism part of it and also about the free body diagram, you mentioned that one mechanism for this injury could be the twisting motion that technically being transferred from the upper body most of the time to the lower body. For some of I don't think that moment would be shown in the free body diagram, if I'm not mistaken, because basically you have some moment that is coming from a torsional twisting movement on the upper body, and then you're trying to see it in the knee. That's one part, and the other part is if I have a larger upper body, stronger upper body versus lower body, and if I do a twisting motion, would I be in more of a risk of ACL injury or not?
I don't know. I really don't know. And I think, yeah, not sure. It's hard to know these injuries. Like I think I'm thinking about NFL football, where these athletes are big humans. Yeah. And also some studies, a lot of the studies that sort of I turn to are cadaveric studies where they try to recreate ACL rupture. And, it's a multi-planar thing. And you can't get it with one range. It has to be sort of this compression, tibial internal external rotation, this extended knee position, and something else is happening, mechanically in that environment. And then the last piece of it is, it seems to be like in the basketball example that I showed in the NBA, it's a technical tactical play that they're doing, which sort of leads you down this road to be like, what's happening from an awareness of the gameplay and how they're controlling muscles, so I think those, you probably would be hard pressed to find any one thing, but a multiple thing. And I don't know about body size, upper body size.
The reason I asked, I'm looking at in the gym, there are people who are just working upper bodies. Right? I'm just thinking if it is possible that they would have more of a chance of losing their ACL, or if there's been any data on that.
I don't know. It'll be interesting though.
That's a beauty thing, has nothing to do with sport. I'm I'm always struggling a bit with the return to sport criteria.
Mhm.
So let's assume you find what you would think is the optimal, the fabulous return to sport criteria or set of criteria. And everybody agrees. What would that guarantee when I go to back? So I had this injury and I satisfy this optimal criteria. What would that mean for me as an athlete?
Well,
Or how do you define?
yeah.
How do you find? Not like what would you measure or strengths
Yeah.
this or that, but really in terms of outcomes. So I'm going back to the sport because I'm clear. What would that mean?
I think there are two thoughts on this, and I didn't get into too much detail on it today, but what are the things that help you get back to your pre-injury performance level?
So I have the same performance.
Same speed, same, and what are the things that prevent you from getting hurt again? Or that would include progression of the injury. And I see it a little bit differently. I went to the eye doctor the other day and he took my eye pressures. And he said, yeah, I'm not expecting this to change for 15 more years or whatever. And then he said, but I'm going to do these pressures all the time because if I notice something in your baseline, I could do something for you. And I sort of see it the same way here, that this idea of criteria is the wrong way. Instead, what we want are sensitive tests that I could follow somebody over time if in an athlete population and say, hey, you know what? Something's starting to look a little bit different here.
So the criteria is kind of evaluated on an ongoing basis.
Yeah.
But essentially, I'm back to performance and I'm at a level where I'm about equally likely to get injured before I had that injury. So rather than 2 or 3 times the risk, I'm now at the same risk as everybody else.
Yeah, I think that would be the ideal. And I actually think they're different. That's would the criteria that predicts you not getting hurt again be the same criteria that predicts you performing again? There might be a reason why lots of athletes decide not to come back after the injury because it's a traumatic injury. I don't know.
Because I always think, we talked about that before. I always think that there are sports, where the ACL gets injured, like soccer or basketball or so, and skiing, alpine skiing. But then there is sports, when you go back, you need the ACL.
Yeah.
Like in basketball or in soccer. Whereas if you ski properly, your skis are nice and parallel.
Yeah.
You really don't need the ACL.
Yeah.
And so for performance,
yeah,
as long as you ski properly, I don't think the ACL is important. Whereas if I'm doing fancy dancy movement on a football field or soccer field, my ACL is probably required.
Yeah.
Like I wonder if that makes a difference as well.
Yeah. I think it does. Yeah. And I think it's one reason too why, if you look at the research on skiers who make it back to the pre-injury performance level, it looks pretty favorable. So they tear the ACL, but then, a high fraction of them are back competing and even back to where they were, winning World Cups and doing whatever. So to me, that scenario is about ensuring they're sufficiently recovered according to some baseline. But in the context of field and court sports, I mean, it's amazing, 55%. And I think that's probably due to the fact that there is just that extra rotational demand from pivoting and cutting and
The other thing is also the male-female, female basketball players get injured more often, have more ACL tears than males, but in skiing it's about the same.
Yeah.
I always think in skiing it's probably as much related to not really strengths, but really as much as you're taking risks.
Yeah.
In basketball, you're not taking a risk when you tear your ACL. But in skiing, normal skiers usually don't tear the ACL, but normal skiers, they don't go down at 140 kilometers on a completely icy thing,
Yeah, I totally agree. Yeah, I totally agree. I think there are things there that are washing that out. No doubt risk taking is a big piece of that for a skier. And not so much like, because I think in the context of basketball or soccer, you're just playing the sport and then bam, to your point, you're not taking a risk per se. You're just making a cut. So
the last thing that I had, just to remark, actually I have a couple more, but in your model that you have, I was wondering if maybe there should also be a recovery from training strategy, like if you get enough sleep, if you get massages after the training, if you do this, if you do that, would that potentially
I think it would be, and I think it would be actually a back to this model, but it's one of the things I didn't put up here for simplicity's sake because I didn't have enough room on my graph on my slide to put it in. But this idea that you have, and especially in a collegiate environment, so you're transitioning from high school to university, you've got social load, fatigue factors related to just being a student. And certainly one of the pieces that we've highlighted here that I didn't put in, but would be the idea of sleep, and this idea of what's the effects of that on our, what we call perceived fatigability, which is how you feel tired today, versus performance fatigability. My muscles aren't working the same because they're diminished because of fatigue factors. So, we're trying to create, and Zach is trying to create little models around each of these pieces to say, how could we study this in a systematic way? But I think that's pretty crucial piece.
Just a little tiny thing. I was fascinated by the patella tendon autografts, if I understood it correctly, was performed a little bit better in terms of not getting injury compared to semitendinosus. And do you think that's because of a different behavior here, different neuromuscular thing, or has anybody tested the middle third of the patellar tendon mechanically and the semitendinosus graft and shown that on average the patellar tendon graft is just stronger?
Yeah.
Has anybody ever done that?
Yeah. Yes, they have, and it's because the bone patellar tendon bone graft, they take a chunk of your patella and a chunk of your tibial tuberosity. When they put it in the tunnel, the bone heals the bone. Whereas with the semitendinosus graft, they use a hook, they use a button hook. So they literally attach a little thing, they fish it through, and they hook it down in the back. So it's actually not it's a hook it's a button that's keeping you in.
So it doesn't grow in.
Yeah, so that's one reason why the bone patellar tendon bone graft is thought to be a stronger graft.
But has anybody just done material testing?
In
a machine, an instrument machine, if one is stronger than the other?
Yeah, and I believe, from what I can remember, this is memory, but I think in those cases as well, bone patellar tendon bone grafts tend to have a stronger. Yeah, it's an interesting conundrum though, because the hamstring tendons tend to you recover quicker. And that might be something else. Like you're coming back more quickly because you can, and that maybe is a reason why you re-rupture.
Exactly.
Yeah.
So it could be a behavioral thing.
Yeah. It feels better. Doesn't hurt as much. Maybe pain's a good thing in that case. Keep you a little bit safe.
Online question from Robert. Yeah, go ahead, Robert. Robert.
Can you hear me?
Yes.
Oh, you can. Sorry. Matt, you've really convinced me. I thought it was a very thorough presentation and I really liked it. But at the very beginning, your first comment was you were going to try to minimize injury. And well, you've convinced me you definitely don't want to have this injury. But when I look at skiing, and if I look at the pictures you had of the people playing basketball, they were all plantigrade. In fact, when you're skiing, you eliminate your ankles compliance entirely, and you throw all of the movements that would normally occur in the ankle and the foot, and you force them up onto the knee in skiing. And in the basketball, you've got a plantigrade shoe, and your pictures at least showed people running plantigrade. But when I think of every other species, when it performs being chased by some other element or running away from a carnivore, they're all digitigrade and mostly, in fact, working on a single point. And so pivoting and rotation is really accomplished right down at the toe. And in these other sports, we're eliminating it. Now, I noticed that you have an appointment at Edith Cowan University, where I'm sure there would be access to people who do play sport barefoot. There are many in warm environments, not like Calgary. In warm environments, many people will play football barefoot or basketball barefoot. And I'm wondering if you have any knowledge whether when you let the ankle do what it's designed to do you reduce the knee injuries?
I have no idea, but I think that's a really interesting, it's a really interesting point. And the reason I find it interesting is that, I mean, you look at the NFL has got a huge problem with ACL ruptures right now. I don't know where they're at right now in terms of the number of ACL injuries they've sustained, in the last season. But I know that a big question is around the turf, the shoes, the footwear, things that might be contributing to the injury. But I never thought about letting the foot do what it normally does and what the effect of footwear might be on that. Certainly with skiing, it makes a little more sense because you're in a cast and you got a big piece of plastic on the other end. And if that thing goes, it's going to put a lot of torque through your knee joint. But I never thought about that in the context of barefoot versus shoe-borne athletes. It's interesting.
In Northern Australia, many of the, certainly the First Nations people never play in boots. They always play football barefoot. And they're a very significant contributor to football in Australia. And so if you looked at football knee injuries in Northern Australia where it's hot to Southern Australia where it's cold, the information may even be there. Just a thought, but I thought your presentation was lovely. Thank you, Matt.
Oh, no, thanks. That's a great point. Look into it.
So I have two questions. The first one is, you show that there are some tests that you run to test whether they're ready to return to play. So for example, the asymmetry index. Have you tested how that aligns with, you said that the most common way of diagnosing if someone's ready to be back is just how much time has elapsed from surgery or injury. Have you compared what your results from a battery of tests show compared to the time that you think it should take to come back?
Well, I think the only thing that we have to answer that question is that we have, so in practice, it's never just as simple as here's your discharge criteria, high five, away you go. It's in practice, it's the surgeon, the physiotherapist, the mental performance consultant, the coach, the strength coach, the athlete, and it's a shared decision-making process to say, what are all the things that are on the line here, and what's this going to look like, right? So that's the reality. It's the messiness of applied sports science is that you have a lot of people doing things on an individual basis. So all we can do is look at the aggregated data, and what we can show is if we look at asymmetries or the limb function over time with enough data is essentially where are the injured athletes starting to look more like their non-injured counterparts. And it seems like that duration is more on the order of a year and a half, 2 years, and maybe even 5 years if we start talking about that fast force production. And certainly they've been cleared to go back before that. So, because getting back on snow and skiing, it might take you, you might be able to get back on snow at 9 months and ski some easy runs and get your technique back and then work your way back up to, to racing again. And I think part of that process is that we have, in some cases, unrealistic expectations about how quickly that should look. I think we've got sort of a more short-term vision on management of this injury. So we think about it in a 9 to 12 month time frame for getting back, but we know that there's this window where 2 years is where you're typically seeing on average that they re-injure. So I think part of it is, coming back to maybe Walter's point, is that we can't really compare cleanly time versus function, but what we know is it's individual, and we know that it's changing over many years. and that there's a whole dynamic process that needs to be managed that includes the athlete, the coach, the funding partners, all those things need to play into where that athlete tracks back. Yeah, I don't know if that answers the question, but
It does. And the second part of my question was that is it a phased reintroduction? Just where like if you start them with coming into training and then is it your test? Do they say anything about okay now they're ready for competition or
yeah.
how's that?
That's where we ended up. So I mean, when in my final few years with the Alpine ski team, because I'm not working with them anymore that I'm here, we were very much monitoring the athlete. So it would be like, okay, so these data points, this information, let's transition here back on snow with a physiotherapist who is a skier who could help do rehab on snow. We forget about that. Like rehab in the clinic's one thing, but what about having your physiotherapist on snow with you to actually work on your technique, right, and your progressions? So the idea that these are graduated across time is really, really a crucial piece of the puzzle. But what I'm starting to realize is that because it's a team dynamic, right? And I'm saying team, it's the athlete, the scientists, the physical therapist, all these players are in this world, right? Is that every new space you go is very, very different in terms of how that might look. But my anecdotal experiences and what the best evidence is today in the science is that we need to start thinking about it as you described, right? So it's a graduated phase transition where the athlete could be both progressing or regressing away from what's desired. I know we got probably a limited time, but I think this anecdote is interesting. Catching some data from a professional athlete. I won't say the sport, I won't say any details, so it's non-identifiable. But an athlete coming back after a serious knee injury where there is data, they look at this person before training camp, and then they look at this person after 2 weeks of training camp. And in 2 weeks, they regress to the point where they look like they're 5-6 months after surgery. Because they're out there not thinking about rehab, they're playing, right? So we know that these things are really crucially, I think, have to be monitored and time-based, just like my eye doctor, right? Take your pressures every time you come in to see if something starts to change, and then we can do something about it. That's my thought. Yeah.
Thank you, Mike, for the presentation. My question is related with the proprioceptive function of the ACL, the ligaments. So the amount of mechanoreceptors inside, an important amount of them. So in that ligamentization process that you explained, what is the difference for the re-innervation of this graph? So is there any difference in this re-innervation? Is something like that you are looking for? Because I think it's important to know that the ligaments contribute to the feedback from the muscle activity that surround us. That's important joint. So
yeah, I don't, unfortunately, I don't have a concrete answer other than to say that some recent data looks at the hamstring graft and sort of sees that this seems to be taking longer than a bone patellar tendon bone graft. And I think if you, the best thing is to say is take anybody with an ACL injury and ask them to close their eyes and keep their balance. And you'll notice right away the effects of the sensory motor disruption and the neurophysiological injury, right? And so it becomes a big part of, I think, how we understand the injury. It's not been an area that I've studied personally a lot, but I think it's something that, we know from a rehabilitation standpoint is crucial. Yeah.
Because from this point of view, rehabilitation, one of the things that you say, and stuck in my mind, was this experience with this patient that say I am not prepared to return to my sport. So, and you put this roadmap that is super important. I think that's a biopsychological aspect of the rehabilitation. So how, maybe in this rehabilitation process, how do you handle this kind of question about confidence to do super high level motor skills
and, for example, the kinesiophobia or the fear of movement, of the pain.
Yeah.
How you put all this information in one equation? Of course, it's possible, but
Yeah.
how is your approach about this aspect?
Well, so I think it's safe to say, and I'll say it in 3 different ways. Number one, on an individual basis, on a practical basis, is if you are in a scenario where you are working with athletes who are coming back after a traumatic knee injury, we know that the psychological piece of it is essential. And so we can't just say, well, it's time or strength. The second component is it's complex. It's a complex system. So I think part of the answer to the question is we need to start studying it like a complex system, which means that in advance, before we begin doing research, is we have to have these pieces of the puzzle coming in together as a part of the study paradigm. And I think where, again, back to your idea of like, how would you pull all this information together? And I took this slide out, but we're beginning to look at, are there some ways that we can use some potentially machine learning approaches or other ways to take in the vast amount of information and to start to build a picture, of like, it's not a yes, no criteria you pass, but here's a picture of what we think you looked like. Here's what the picture looks like now. And I think that's probably it's probably going to be the best way, at least initially, to deal with the fact that got lots of different factors. We need to know which they are and how they're interacting. And it's hard to study that without something a little bit more sophisticated, I think. Yeah.
Okay, and we're almost at 4:30, so we're going to cut it there. Thank you, Matt.
Yeah, thank you.